Now, for the uninitiated, could you describe a little about, why EUS is such an important tool for physicians?
So I think in medicine, our goal has always been to be, especially with therapeutics, cancer treatment, stuff like that, be as minimally invasive as possible. So certainly in GI, what we're trying to do is always do things that help avoid surgery. And endoscopic ultrasound is a procedure that combines high resolution imaging with the ability to access tissue or provide therapy without cutting the skin. Going through, it's basically natural orifice surgery or diagnosis and stuff like that. And it's a very unique thing that I don't think any procedure will ever be able to do. Like, you can get the best CT scanner in the world, but even if it identifies a 1 or 2 millimeter lesion, it won't be able to biopsy it under CT guidance without going through the skin. Yeah. So ultrasound allows you to avoid, and when you go through the skin, there's always, it's painful. There's a risk of spreading tumor, stuff like that. So endoscopic ultrasound, even though our ultrasound technology, the resolution may not be as great as some other imaging technology, the combination of that resolution with the ability to get up close to stuff and then touch stuff, biopsy it or treat it, is unparalleled. And that's why EUS, I think, has become so important.
Yeah, because originally it really started out as a diagnostic tool or staging.
It was for staging cancers. Yeah.
Yeah, and now, as you said, with the ability to biopsy, it certainly has much greater utility. So what are some of the other advances you're excited about?
Well, I mean, the scopes to begin with are just getting better, smaller, better, better optics. The ultrasound qualities, I think it's been somewhat static, but what's been good is that they've been able to keep that level with smaller probes, which is good. Mm-hmm. What I think is exciting now is that for EUS, we're finally getting devices that were designed specifically for EUS. So at the beginning, when we were doing therapy, we were just using stuff that was made for ERCP and that weren't necessarily easy to see by ultrasound. And what we're finding now is that they're designing things that really can be seen very well by ultrasound, that you don't need fluoroscopy, and that really they're specifically designed for EUS. So even somebody who does ERCP, if they don't know how to do EUS, they can't just do what we're doing anymore. And as I say, it's kind of funny because all those ERCP guys who were laughing at us for the last 20 years, saying that we were a procedure looking for an indication, all of a sudden they want us to teach them EUS. And they're finding that the ERCP volume is going down, and we're taking over more and more of their work. My feeling is that ERCP will be reserved for stone disease, okay. But for everything that's cancer related, EUS will probably be the primary modality.
And are we seeing kind of maybe an in-between period here where we're doing these back-to-back procedures, and is that wise, or will that trend continue to evolve?
The reason we do back-to-back now is because patients who come in with obstructive jaundice, for example, will get which looks like a pancreatic cancer, probably there's a mass on CT or something. In our center, they get an EUS first for a diagnosis, and then they go to ERCP for biliary drainage. Yeah. But we're actually currently doing a randomized trial of EUS guided drainage for distal malignant obstruction versus ERCP. It's actually a Canadian trial being run by Yenny Chen at McGill. And I think that we're going to show that if EUS can see the bile duct properly, it's better to just, while they're there for their biopsy, to do the biliary drainage at the same time. It saves the procedure. The EUS guided biliary drainage literally takes about 20 seconds. Once you're in there, you put in the device, click, you've got the drainage done, and you're out. And there's no wire exchange, there's no fluoroscopy. The long-term occlusion rates of the stents appear to be very good. There's no risk of tumor ingrowth because we're not going through the tumor like ERCP. And I think it's really going to, as I say, it's going to eliminate the need for ERCP for distal obstruction. For hilar obstruction, the EUS approach is more of a transgastric hepatogastrostomy approach, and the device for that's a little bit more complicated procedure, and they're working on making a like a lumen-opposing metal stent for that, which is the easy sort of click device, but they're still not there. But if that comes out, then there's really all you RCP's going to have left is stone disease.
Okay. Now, I've also seen you speak at a few conferences, and you've been fairly outspoken about taking samples and biopsies. And what are some of the biggest misconceptions that you see out there that still happen quite a lot that you think don't add a lot of clinical value?
About tissue acquisition?
Yes.
I mean, misconceptions from other
clinicians.
I guess they may think that it's that EUS is sort of complicated to do, or that we don't get great tissue. But honestly, an EUS guided biopsy of a pancreatic mass, it's somebody who knows how to do EUS, literally takes about 3 minutes. Our needles now are no longer doing just cytology. We have amazing core needles that have a diagnostic accuracy of close to 99% for both benign and malignant disease. So it's important not just to diagnose cancer, but if there's no cancer, to provide a diagnosis of a benign pathology, so you don't keep going back to repeat the biopsies. So I think what I found at the beginning of EUS, certainly, for example, in the mediastinum, which was sort of a very hidden place where you could only access by surgery. When we started doing mediastinal node biopsies, the pulmonologists and the thoracic surgeons just couldn't believe we were getting this tissue from a compartment that was so inaccessible before. We were doing it in a minute. It was in sick patients with almost no sedation. And I think some people who aren't familiar with the US don't understand how easy it is to get access to so many different areas with such high accuracy.
Wow. And when you look at where EUS is going, and where would you like to see the technology evolved? From an R&D perspective, what would you like to see the systems be able to do?
So I think the smaller the better, as long as the scopes don't get too floppy. You need a certain amount of rigidity in the scopes to get things done in some difficult situations. Personally, I think the scopes now, even the therapeutic scopes, are almost the same size as a gastroscope. So I don't think there's much more work to be done there. As I say, I don't think the ultrasound image needs to get that much better. Better would be great. I guess more penetration would be good. My goal is not really to improve the technology that much. I think that being said, there's some people who are very keen on a lot of almost trying to get the system to do the work for the doctor. Like you just put it in and it lights up all these colors and tell you what the diagnosis is. I don't think that's going to happen ever. Like just never. Yeah. I mean, you can't just let a machine. You have to be able to position the scope properly. You need to be trained. You can't just stick it down and expect the system. Even CT scanners. You still need somebody to read the scan.
Right.
There's some interesting, this technology of elastography, where this sort of optical biopsy, which I think is being used too much in malignancy. I think there is some hope for it in non-malignant disease, so that might be something to be worked on with some better studies, because I think the quality of the studies is lacking because they've been focusing primarily on cancer.
Right.
My ultimate goal, I think, for EUS, if you say the technology is pretty much where it needs to be, is to get it in the hands of more people. So I think that we need to get EUS taught at the beginning of GI training, not at the end. And it should basically replace the gastroscope. So if it's the same size as the gastroscope, but it allows you to do endoscopy and ultrasound and tissue acquisition and maybe therapy, I think it should be the workhorse scope for everybody who's going to get an upper endoscopy. May as well get an EUS instead of a gastroscopy.
So for the payers out there, whether it's in a public system or a private system, what's the argument for doing that?
So EOS scopes are certainly more expensive than regular scopes. Initially, they broke very easily because they were mechanical scanners. But now with the fixed array scanners, if your people know how to take care of them, they're very durable. For sure, if you do break the ultrasound portion, it's expensive. But the cost per procedure obviously goes down depending on how many procedures you do. So if you do one procedure a year with a $100,000 scope, that's a very expensive procedure. But if you do 3,000, the cost per procedure goes way down. And then this scope, and the information you get will, allow you to avoid doing a lot of CT scans, repeat biopsies. It'll upstage a lot of patients with tumors so they won't get inappropriate surgery. I think it'll help outcomes by more. I think the more precise the staging is, presumably the better outcomes you'll get because you'll be able to provide the most appropriate therapy, and you won't be over treating people who have, unfortunately, more advanced disease than you think it is. So I think in the end, it's an ambulatory procedure. So you keep people out of the hospital, but then, payers can say, well, if you keep people out of our beds and you keep cycling them quickly, there'll just be more beds to bring in people for surgery. So in the end, you'll end up doing more operations and it'll cost more. But if the goal is to really do the most efficient procedure that provides the best outcome for the dollar, I think there's definitely an argument for something like EOS.